Welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Joyelle Ray Alexander, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we will be taking your questions throughout the hour by phone. The toll-free number is 800-452-0662, or you may send your written questions by fax. The fax number is 518-426-0696. We will also be taking questions by email. Please email us at any time throughout the hour at phlive.newyork@gmail.com. Today's program is Preventing Teen Pregnancy, Lessons Learned in New York State. Our guests are Kristine Mesler, Associate Director of the Bureau of Maternal and Child Health at the New York State Department of Health, and Dr. Jane Powers, Project Director, Act for Youth Center at Excellence at Cornell University. And thank you both very much for being here. It's a pleasure to have you.
Well, thank you for having us.
This is a very timely and important topic. And let's just, Chris, before we dive into our topic of teen pregnancy, tell us about the Bureau of Health and Child Health and your particular role.
Okay, I serve as an associate director in this bureau, and this bureau administers a variety of programs that focus on the promotion of health and wellness for women, infants, and children, and the prevention of adverse health conditions. For example, we work on ensuring the availability of reproductive health care to all residents of New York State to prevent unintended pregnancy. We work on promotion of healthier babies. We work on the reduction of the violence against women and its impact on women and their family and the communities. The Bureau has been the lead in adolescent pregnancy prevention since the 80s.
Okay, so that's the Bureau of Maternal and Child Health and your role. And Jane, tell us a little bit about the Center of Excellence and your relationship with the New York State Department of Health, if you would.
Sure. Well, since 2000, we've been funded by the New York State Department of Health to operate an academic center of excellence. We're part of an initiative called Assets Coming Together for Youth, which seeks to promote the health and well-being of adolescents through positive youth development strategies. Now, positive youth development is an approach that helps communities build the capacities and competencies of our youth and doesn't view them as problems waiting to be fixed, but instead perceives and treats young people in a very different way, as assets, as resources, as problem solvers. Now, the Center of Excellence is actually a partnership. Although we're based at Cornell University in Ithaca, New York, at the Bronfenbrenner Center for Translational Research, we work with several partners. Our medical expertise comes from the University of Rochester Division of Adolescent Medicine, and we also work with the New York State Center for School Safety in New Paltz, New York, and our downstate reach is provided by Cornell Cooperative Extension in New York City. Essentially, the Center of Excellence links the academy with the field. We translate research and best practice information for easy access and use by policymakers and practitioners, and we provide training, technical assistance in the areas of positive youth development and adolescent sexual health. As an intermediary organization, we work closely with program providers or grantees, which the Department of Health funds. And so in this presentation, we're going to be talking about those grantees, those providers who prevent teen pregnancy.
Okay, we're off to a great start. And Chris, would you tell us why this particular issue is a high priority for the Department of Health?
Certainly. Adolescent sexual health outcomes are a priority and an integral part of the National Healthy People 2020, as well as the New York State's Department of Health's prevention agenda. In New York State, we want the best for all teens. We want teens to be able to have a healthy and happy adolescence and transition into a healthy and productive adulthood. New York State has made significant progress on this issue with this public health issue, and teen pregnancies really do incur a tremendous social and health cost for both the individual, their children, and certainly for society in general. Early pregnancy disruption disrupts the normal course of development for adolescents. Adolescence is normally a time when people are continuing their education, making determinations about their future careers, and certainly interrupting this process with early parenthood disrupts it for not only the mother but for the male as well. Pregnancy at this young age also really puts that woman, her child, and potentially the father at risk for perpetual poverty and public dependence. Young fathers are less likely to marry the mothers of their children, are more likely to have lower educational attainment and earnings, which really hurts their child's chances at social mobility. We know that women who are pregnant during their adolescence are likely to receive later no prenatal care, more likely to have premature infants and babies that are born with low birth weight.
What is the current picture in terms of teen pregnancy?
Well, fortunately, the teen pregnancy rates are at an all-time low, which is the good news. We know that teens are really to take credit for this themselves. They're engaging in less sexual activity and are more effectively using contraception than they have in the past. Yet nationally, 3 out of 10 girls still get pregnant by the age of 20. And of great concern to us is the significant disparities among white, black, and Hispanic teens.
And how are we doing in New York State?
Well, in New York State, we have currently, the last year that we have full data for is 2009, but we still have 54 15 to 19-year-olds becoming pregnant, per thousand that is, 15 to 19-year-olds becoming pregnant, and that represents over 37,000 pregnancies. Yet, the optimistic side is that this represents a 43% decline from the peak in 1993. As you see on this particular chart, we've broken this down by region, and we can see that we have a significant higher rate in the New York City area versus the upstate area. The unintended pregnancy rate for teens is estimated to be at around 87%, which is a very high rate. Currently, we still have over 16,000 infants being born to teens each year in New York State. And as I had mentioned before, we have these significant regional disparities. Also of concern is the ethnic disparities, as we'll see on this next slide. We know that in New York State, African American and Latina teens are 2 to 3 times more likely to become pregnant during adolescence than their white counterparts. Now, when we compare this over from 1994 to 2009, over a 15-year period, we can see the dramatic declines for all age groups within all racial and ethnic breakdowns. And again, these are significant declines, but when we look at the next slide, we can see that these declines have not been as great for Black and Latina teens. We know that the white counterparts have had a greater decline.
And Chris, can you tell us how New York State is doing in comparison to the rest of the nation?
Certainly. Again, this is something that we can be proud of. New York State has had long-standing programs and a real commitment on the part of the state to this issue. As early as the 1990s, New York recognized the need for more comprehensive, multidimensional programming we'll be talking about a little bit later on. Teens need more than sexuality education and access to reproductive health care. They need motivation to engage in positive and healthy behaviors. The connections between youth, family, school, and community is critical, and programs must provide the opportunities for youth to develop assets to ultimately support their transition into adulthood. We know that our programs all work to improve this access to reproductive health care and to provide these additional opportunities for young people. Currently, New York State has the 6th lowest adolescent birth rate in the country. We have the 2nd lowest rate for Black adolescent females and the 5th lowest for Hispanic adolescent females, which again is something to be very proud of.
Now, if teen pregnancy and births to teens are at an all-time low, and New York State is doing comparatively well, as you've pointed out, why did New York State see the need for taking a new approach?
Okay, that's a great question, and I appreciate the opportunity to talk about that. Pregnancy prevention is different than other public health issues. It's not like we eradicate the problem, such as we can eradicate polio or smallpox. We know that there's risk and protective factors within the individual, the family, and the community that impact adolescent sexual behavior. Although rates may be currently low, the underlying risk factors exist in the communities, and it's important to target these factors to improve the sexual health outcomes. First of all, we need to look at our new target populations. We know that across New York State we have increasing amounts of new populations settling throughout the states. We know that we have real migration from the New York City area of new immigrants throughout the state. The literature says that every 3 years we have a new target population. So there we may be doing great intervention today. That target population ages out and we have a new population replacing them. So we have this continual need for intervention. We know that it's important not to have inconsistent service models such as in the past, and instead we've really gone to an approach where we are implementing only evidence-based comprehensive sexuality education. We also are looking at, rather than targeting just pregnancy rates, looking at the underlying factors within the community which support those risk and protective factors. We know that teen pregnancy is closely associated with poverty, with communities with low educational attainment, a real sense of hopelessness within a community. When we target only based on pregnancy rates, we aren't looking at the size of the populations that we're trying to impact as well, and trying to get the biggest impact on this burden. We also know that we had to look very critically at these significant racial ethnic disparities and really target more of our efforts to communities of color in order to really improve the health of all teens in the state.
Thank you very much for that information. Now let's hear from some folks in Rochester, New York, a community that has been pulling together to meet the problem of teen pregnancy.
As an adolescent medicine specialist, I tend to see teen pregnancy in a very comprehensive way. So it has biological issues, psychological issues, social issues, educational, economic, not just for the individual who gets pregnant and the person who makes the pregnancy, but also the baby, and society in general has to kind of see this as a potential problem, because we know the issues associated with, especially an unwanted or unplanned teen pregnancy, has very far-reaching effects. And so I think we have to really come to deal with these issues in a very comprehensive way. The data we are seeing with respect to teen pregnancy coming down from its peak in the 1990s, I think is encouraging, but I think we have to realize that although the data overall are encouraging, there are still areas in our country, especially areas in the city of Rochester, that has continued problems that we need to be paying attention to.
When I think of the systems that impact our children, one of my great fears is that we don't talk to each other nearly enough. And when I think of our at-risk youth, I think of the factors that really put them at risk: early incarceration, mental health, access to drug and alcohol, homelessness, and of course early pregnancy before the age of 18. And one of my tasks, I hope, is to bring those systems together. My great optimism and my great hope for this community is that we begin to see those factors, those social issues, as intertwined. You know, early pregnancy, teen pregnancy, and I run a homeless shelter for teen moms. I have 8 young women and 6 babies, and so I have firsthand knowledge. But their issues are often not just linked to an early pregnancy, and my fear is that we try to pigeonhole and diagnose the issues as if they didn't have anything to do with each other. So for me, it's a comprehensive approach. Look at those 5 factors. Almost every one of our young women who is at risk of an early pregnancy, and then another, is also at risk of homelessness, is also at risk of being in a poverty situation, which may lend itself to early dropout from school, or access to mental health concerns, or concerns about drug and alcohol. We've got to have our systems talk to each other.
I think the main focus for the organizations and the individuals who work with youth in Rochester, everybody shares the same main focus. We want youth to succeed, and we want teen birth rates to decline. We want youth to be healthy and make healthy choices. So sure, we are sometimes competing over grant funds. We're competing over attention, media attention, etc. But that's really a minor part of it. There's so much more that we agree on. And we found that when we work together and support each other and learn from each other, a health clinic can learn from a youth leadership club. A school district can learn from a city rec center. A settlement house can learn from a public access TV station. And really, people enjoy that so much, reaching out of their own box and interacting with somebody in a different field, that it's just really a win-win.
Well, it's certainly great to hear about the work that the folks are doing and how passionate they are in that particular area in Rochester, New York. It's just terrific. It's terrific. And Chris, once the need for a new approach was recognized, how did you go about developing it?
Well, we really needed to reach out to the topic experts on this subject. And within the Department of Health, we have a tremendous amount of expertise. We looked across the state and nationally at who the experts were on this particular topic. But most importantly, we reached out to young people across New York State themselves. We know that they, of course, are the topic experts on adolescent sexual health.
I love what you say about they are the topic experts. And Jane, what role did the Center of Excellence play in the planning process? I know that you've been on the ground floor of that. Let's talk about that.
So we were approached by the Department of Health, and they wanted to take a fresh look at adolescent sexual health, and were their current programs and strategies in line with the most cutting-edge knowledge in the field. And so we did something absolutely fantastic with them. We convened a symposium, and we wanted to learn and explore the latest research and best practices regarding the promotion of optimal sexual health. And so we brought together the top experts in the field with practitioners and policymakers and emerging leaders and health advocates and youth to inform future DOH initiatives. We collaborated very closely with the Department of Health on the planning and organizing of this. And so just imagine, you could say, who do we want to bring together? You know, the top people in the field to have this conversation. And so we had quite a distinguished group of experts. Sarah Brown from the National Campaign to Prevent Teen Pregnancy, Michael Carrera from the Children's Aid Society, Alwyn Cohol from the Harlem Health Promotion Center, Angela Diaz from Mount Sinai, Doug Kirby from ETR Associates, John Santelli from Columbia University, and more. And we also drew upon experts, representatives from New York State agencies and New York City agencies, including the Office of Children and Families and OCFS, Office of Children and Family Services, the Office of Mental Health, Department of Justice, Department of Education, some long-term providers that you worked with, Planned Parenthood of New York City, the Hetrick Martin Institute, Mount Sinai Medical Center, as well as advocacy groups. And then we had a panel of young people, 5 youth, who served as discussants. So following each presentation, the young people had the first dibs on making a comment or, you know, having a reaction. So during the symposium, we addressed 4 major themes. 1, current trends in adolescent sexual behavior. 2, what are the disparities in access to sexual health services, information, and education? We also looked at ecological influences on adolescent sexual behavior and the use of new information and communication technologies. What can we learn about how these new forms of technology are influencing? Additionally, participants were asked to generate ideas for the design of a comprehensive sexual health initiative. What would it look like?
You mentioned sexual health, and before we go into the symposium and what feedback that you received from the focus groups, Chris, so that we're all on the same page, how do you define sexual health? What's the operative definition of sexual health?
Well, actually, our adolescent sexual health work group, which we developed in 2006, actually worked on this, and we defined, we had representatives from all the Department of Health programs that in any way impact adolescents. The people from the Office of Health Insurance Programs, the Bureau of STD, the AIDS Institute, the Office of the Medical Director, Immunization, Indian Health, really quite a wide group within the department. And what we did is that we defined what we felt as a sexually healthy adolescent was. And we really wanted this as our common goal. And I think we have a slide on this where we really look at the definition of adolescent sexual health, that they are able to set appropriate boundaries for themselves, that they have the knowledge to be able to make appropriate decisions for themselves, that they feel that they have the ability to access information confidentially from healthcare providers, from within their educational setting, and certainly from their parents, that they're able to make the best decision for themselves.
Okay, that's a great foundation. I think it's very important that we have a working definition of sexual health in light of what we're discussing today. Now, Jane, I understand that in addition to the young people who served on the symposium that you referred to, the symposium panel, you got input from youth from throughout the state. Why don't you tell us a little bit about that?
Oh, certainly. So those of us in the youth development world take the notion of youth participation and youth engagement very seriously. Youth voice is one of the fundamental tenets of the positive youth development approach. And this means that we work with young people, not for them. And we bring them to the table, engage them as decision makers and as planners and as implementers to work on the issues that impact their lives. We listen to their expertise and their perspective. I mean, one of the common mantras that's said among youth organizations and young people is, don't make decisions about us without us. And so that's a really, really important part of our work, is to engage young people.
Now, for this program, you spoke with partners and providers in Rochester, as well as young people who have taken leadership roles in teen pregnancy prevention. Let's take a moment to hear from them.
Basically, what positive youth development is all about is realizing that young people have many, many intrinsic strengths. And what adults need to do is, by and large, get out of the way. Prepare young people for successful adulthood, but doing that in partnership with them. So I think that, the so-called 5 C's of youth development, adults can help young people develop character, connections, competence, confidence, and caring, but they need to do it in a way that isn't the old top-down adults telling young people what to do, but actually engaging youth in a way that we facilitate them doing what they want to be doing on their own, so that they can become healthy adults. I think youth development is also positive because it's really fun engaging young people in this kind of a way, because they feel respected, they feel honored, and they feel that what they do matters. And I think those are important elements of the youth development model.
For adults, my advice is to be positive and remember the youth that they're talking to, and to also think in a youth perspective.
Just make sure that they know that you're there for them and that you will help them to get through what they need to get through. And just make sure they know that you're there, because if they don't know that you're there, then they're not going to come.
I believe that adults should be more supportive, and when you talk to youth, don't talk down to them, be on the same level as us, and make it more comfortable and a comfortable environment, so we know that we can trust you, we can come to you about our situation, so we know that we have somebody around.
One of the things I see happening is where we have mentoring and adult intervention and meaningful relationships, our kids engage. When kids are disengaged and when they're out of the home or out of school, they are at great risk for teen pregnancy and for homelessness both. The notion that we would look at our kids with compassion and connections and cooperation and care is just brilliant. And the notion that we're doing that every day is just not there. I mean, I wish we were, but we're not. So as we think about systems and changes, how do we approach our young people the way we do most people, with respect? At the Center for Youth, we have a theme. We give them good information and we rely on their choices. Now, they slip and fall, they make mistakes, but good youth development has a deep trust in our kids and the fact that given good information and respectful acknowledgement of who they are and where they come from, they will make good decisions. And youth development really is finding their potential and trying to do everything we can to keep them out of harm's way. We have to believe in our kids.
One of the things that I've learned in the last 12 years of working with New York State Department of Health and New York State AIDS Institute regarding a number of issues in the youth development model is that if adults try to do things for youth, we generally get it wrong. And the whole point behind youth development is we really have young people telling us what needs to be done, what their needs are, and then we can facilitate what needs to happen. And so to have people who recognize that at leadership levels in the New York State Department of Health, in the Division of Family Health, in the Bureau of Maternal Child Health, all the way down, realizing that there is a real value in youth development programming, not just to focus on teen pregnancy and not just to focus on health issues, but to focus on our young people growing into healthy, happy, and productive adults.
Well, it's really great to hear the perspective of youth, and clearly, you know, I can understand how important getting that perspective is. If you're going to have a successful approach to teen pregnancy prevention, you have to have the input and the voice front and center of the youth. Now, Jane, can you talk to us about some of the focus group work that's been done?
Sure, and we're frequently called upon by the health department to bring in youth voice to their work. So just prior to the symposium, at the request of the department, we conducted an extensive series of focus groups, 27 of them, reaching close to 300 young people from across all corners of the state, from very, very diverse sectors in terms of race, ethnicity, gender, sexual orientation. We also talked with runaway and homeless youth, and we did several focus groups with HIV-positive youth. And we wanted to learn, how do young people across New York State get information about sexual health? Where do they get it? What are the best sources of information? We also wanted to know what's been their experience accessing treatment and services, and what kind of barriers have they faced during this. And then we wanted to get their ideas, and this was really important, about improving adolescent sexual health care. How can we make things better for them and their peers?
Now, Jane, as you gathered all of this input, what did you learn?
Oh, we got a lot of information there. From talking to researchers and practitioners and teenagers through the focus groups and the symposium, really came down to 4 areas: education, access to services, technology, and supportive environments for youth development. Now, the theme of addressing disparities ran through each of these different topics. But when it comes to education, young people really want the truth. Tell it like it is. Don't sugarcoat it, okay? And, their call for comprehensive education has long been supported by most parents, and it's also echoed by practitioners and researchers. Now, over the last 20 years, we have a lot of evidence about different sexual health curricula that have been developed that include abstinence education along with information about condoms and contraception. Researchers and program developers have learned a lot about how to improve adolescent sexual health behaviors. And we now have a number of proven programs that work. And we have federal funding actually supports communities in using these evidence-based programs, or EBPs. And we'll be talking about that a lot in the remainder of the program.
What about access to services? How does that factor in?
Now, access to services was another topic that the youth, the providers, and the researchers dug into. Now, in the focus groups with youth, it became very, very clear that many young people just don't know where to go for services. We also asked them, what stops you from going? And many people talked about fear. I mean, the theme of fear was pervasive. I mean, it was fear about finding out bad news. What if I have something? It was fear about parents finding out, fear about not being treated with respect, fear about being judged, you know, fear about pain from treatment. It was, you know, lots of fear out there. We also heard them talk about the need for better access to services that are respectful to them, and many groups raised concerns about the cost of services. Now, researchers at the symposium called for breaking down barriers. Often STD and HIV clinics treat in one place and pregnancy is in another place, and the researchers called for greater communication and kind of a one-stop shopping model. Youth and clinicians alike also discussed the benefits of having a primary health care provider offer sexual health care services. And in rural areas especially, they talked about having school-based health centers provide sexual care. I mean, when you go to a nurse's office, nobody knows if you have a headache and you're going in, or else you're going in to talk about birth control. Also, technology in today's world offers many new ways to reach out to young people, and Al Cohol and Deb Levine gave us at the symposium several wonderful strategies on how we could incorporate that into our work, which we have in New York State, including using text messaging to remind people to take birth control or about their appointments, and also the use of computer-assisted interviews so that young people could ask sensitive questions anonymously and feel more comfortable rather than with asking these questions to a provider.
Fantastic. And Chris, how did all of this information gathering translate into priorities and strategies to promote adolescent sexual health?
Well, that's a good question. We really took a time to step back and really take in all this information from both the symposium and this focus group study to set new priorities for our new pregnancy prevention initiative. We wanted to incorporate evidence-based programming that was appropriate for the gender, the age, and the stage of development, and the cultural or ethnic population that was being served. We know that certainly the education that would be provided to a young person in late elementary and middle school would certainly be very different than what would be provided to an older high school age student. We wanted to look at ways to improve access to a full range of coordinated services that are delivered confidentially and efficiently for young people. We have to recognize that young people frequently don't want to plan ahead to make an appointment, maybe would prefer drop-in hours. We also wanted to mobilize the talents, the skills, and the assets of both the adolescents and the supportive adults within the target community. And we really need to bring in all sectors of the community, whether it be the faith organizations in the community, the businesses within the community, certainly the schools, and all the health and human service providers within the community. We also look to technology to raise awareness and provide information, improve the clinical services, some of which Jane has talked about already, but also looking at the best ways to communicate information to young people. Certainly, they're not as likely to pick up and read a brochure that maybe you or I would pick up, but rather looking at ways to reach them through the internet, through text message services. We also wanted to look at increasing the capacity of healthcare providers to effectively serve adolescents in primary care and specialty care settings. Whenever a young person is interacting with a healthcare provider, their sexual health should be addressed right along with other parts of their health, their dental health, their visual health, their breathing, their heart, everything else. It shouldn't be separated out, and really increasing that competency of healthcare providers in New York State.
And how did the Department of Health set priorities among all of the communities that would benefit from funding?
Okay. We previously had only used teen pregnancy rates, which is really sort of a snapshot in time where you're looking at the number of teens that became pregnant within, we use a zip code as our unit of measure. And we really wanted to look beyond that. We know that they're very sensitive to the underlying factors within the community. So we looked at the different antecedent antecedents that influence sexual behavior, such as poverty, the percent of immigrants in the community, the racial ethnic breakdown within the community. And we know that some of these are protective factors and some of them are actually risk factors within the community. We want to come up with a single multidimensional measure calculated at the zip code level that is based on these antecedents that influence sexual behavior. Our objective was to incorporate different aspects of the communities, but really have that index driven by the teen pregnancy and STDs. We considered a variety of factors: the size of the adolescent population, the actual burden of adolescent pregnancies and STD cases, and demographic and community factors. We looked at this to really drive some of our funding decisions, and one of the common comments that we get back from the field, from our providers, is, well, I did a great job. I lowered the teen pregnancy rate. Now you're taking my funding away. And as I had mentioned before, we know that where the rate may be lowered now, if there is underlying risk and protective factors in the community, particularly risk factors, we know that we will see increases. So we wanted to be able to stabilize some of this funding to really look at who were the communities within the state which were most likely to have the high burden of teen pregnancy and STD rates.
Tell us a little bit about the new initiative regarding comprehensive adolescent pregnancy prevention.
Great, thank you. That's a great question, because we really looked at a time, now is the time to take all of this information that we've gathered from our stakeholders as well as from the experts and really look at redesigning our programming. First of all, we looked at what our current programs were, and we looked at what were the best lessons that we've learned from those programs. We've had a long-standing community-based adolescent pregnancy prevention program and our APPS program, and we looked at what was working well within these communities and for the providers that were providing the services. We combined the funding from these two programs into a single initiative and did a requirement of implementation of evidence-based comprehensive sexuality education. As Jane has mentioned, we have a tremendous amount of research on this area, and we were able to draw in a lot of information from the national research on this to really be able to choose the best programming within communities. So we require this evidence-based programming, and we require that all of our providers assure access to comprehensive reproductive health care that is confidential for young people. All of this work must be done within a youth development framework where we're really looking at the developing the assets of all the participants in the program.
Thank you. And Jane, tell us about the core strategies and the research behind them. Let's talk, or if you would, let's start with the mandate to provide evidence-based programs.
Okay, so the first core strategies of the initiative mandates that the providers implement an evidence-based curriculum appropriate for the young people with whom they're working. And this is new. This is new for people, that they have to use evidence-based programs. It requires that education be comprehensive and include abstinence education, and ensures that young people know how to protect their health and reduce risk when they do become sexually active. Now, in recent years, funders have called for greater accountability and demonstrated effectiveness of prevention and intervention programs. It's reasonable. They want to fund things that work, and this has resulted in a huge wave of interest in these evidence-based programs, these EBPs. And these are programs that have been rigorously evaluated and demonstrate that certain approaches and strategies can positively impact important social problems, such as teen pregnancy, substance abuse, delinquency, and family violence. We have EBPs in all kinds of different areas. They have scientific evidence that they work, and there are a number of advantages to using an evidence-based program. First of all, given limited resources, it makes a lot of sense to use something that we know that works and that will get to the outcomes that we want to see. It increases the odds that we are going to get to those outcomes. Also, instead of putting resources towards developing programs, we can use things that are packaged and have training and technical assistance all together. And because they've been proven to be effective, you create better community buy-in as well. So in the field of adolescent sexual health, we have a strong body of evidence that programs can delay sexual activity and improve contraceptive use and reduce risky sexual behaviors. However, when it comes to taking these programs, that have been developed and tested under research conditions, and then taking them to the field, scaling them up and implementing them in communities are research-based. Our knowledge is much more limited. And in fact, it's complicated to implement these programs in the field.
Well, speaking of how complicated it is, what challenges do evidence-based programs present?
So, you know, it might sound simple. Oh, here's a program, we can just now go do it, just implement it, but it is complicated. So, you know, first you have to choose a program that fits the community, the population, the program setting, and the capacity of the organization of the providers to implement it is crucial. Another issue is that evidence-based programs have been evaluated with particular populations, and we can't assume that they're just going to work across the board in other populations. So, for example, a program that's been tested with a group of Latina girls in inner city Los Angeles, will it work with rural white girls in Oswego, New York? We don't know. We don't have programs that will help us make a difference with all of the populations with whom we want to reach. For example, rural, foster care, LGBT. And another limitation of evidence-based programs is also the materials are sometimes beyond the literacy level of the young people who are participating in the program. And they also are not inclusive with regard to content around LGBT and language that's used. So, providers who are implementing have to make some modifications or adaptations along the way, but that's very tricky because it's very important to implement it with fidelity and as it was designed.
Well, what do we know about implementation?
Okay, so this whole, you know, new field of inquiry has just kind of been emerging over the last few years, a new science, the implementation science. And there's a lot of conversation about this, about implementation. And what we know is that implementation matters, and that achieving good implementation increases the chances of program success, and that we will get stronger benefits for the participants. But if the EBPs are not implemented with fidelity, which means staying true to the original program design and implementing it as the designers of the program and intended it to be implemented, we're not going to get those outcomes. And also, we have to pay attention to quality. So, you know, all of this is really important in terms of implementation. And as a Center of Excellence, we are devoting a tremendous amount of our energy into monitoring how these new grantees have been implementing. Are they implementing it with fidelity? We've developed all different ways to measure this, and we have lots and lots of data that we're crunching right now. And
what opportunities exist within the implementation science model that we can learn from?
Well, this initiative is giving us a great opportunity to learn and advance our knowledge, not just in New York State, but really to share it with others. You know, this is a huge, huge area of interest across the country. So given where the whole field of implementation science is right now, we're in a unique position to do some cutting-edge work. You know, we can look at how do evidence-based programs work in different settings. How do they work with diverse youth populations? What adaptations are needed to make them work more effectively? And outside of research conditions, are EBPs successful in getting to outcomes?
Chris, let's turn to the next core strategy in the Pregnancy Prevention Initiative. Take us through that.
Okay, the second core strategy requires all of the providers to improve access to the adolescent sexual health services for the youth that are in need of services. The providers must formally link with a family planning provider that will accept the referrals. They are expected to identify the barriers to service and identify strategies to break down these barriers. It may be creating a more teen-friendly or respectful environment at the clinic. Teens don't want to necessarily come in and see their next-door neighbor as the receptionist. Confidentiality, as we had mentioned, is key. It may mean adjusting the service hours so that there's increased after-school time for teens or weekend Saturday morning clinics. Also walk-ins. We know that teens are aren't necessarily able to plan ahead and need services when they want services immediately, so that we do encourage our providers to facilitate walk-in hours, especially for teens. We also want the providers to be very sensitive to addressing the barriers that may be impacting teens accessing services. The teen may be identifying as LGBT or T. They may be disabled. They may have been previously sexually abused at a younger age. So we really do training, as well as expecting them to receive training on these special needs for particular adolescents.
And I know in Jane's earlier discussion, she talked about technology. What about access technology in reference to this initiative?
Okay, we know that this is a generation that really lives on technology, so that we feel it's very important to integrate that technology into the provision of services. As Jane mentioned, some of the clinics will actually have teens answering questions online. It's easier to give sensitive information to a computer screen than face-to-face with a healthcare provider. They also use the technology for providing outreach information, publicizing their services, also as reminders. You're due for a recheck, we need you to come back. They'll do text messages and other social networking to really advertise their services.
Terrific. And Jane, the last two core strategies for the initiative are more broad. How do these strategies relate to teen pregnancy?
Okay, so core strategies 3 and 4 is really where youth development comes in. And we're talking about expanding opportunities and improving environments for youth. And how can we help communities organize themselves to support healthy youth? So over the last 30 years, researchers have identified a broad range of risk and protective factors that influence adolescent risk-taking and sexual health. Doug Kirby and his colleagues at ETR Associates and the National Campaign to Prevent Teen Pregnancy have disseminated careful synthesis and analysis of what works in teen pregnancy and STD/HIV prevention. And their work has helped us zero in on the specific risk and protective factors that programs can influence. But as Kirby and others, researchers and practitioners, all agree, curriculum-based programs can't do it all. Many, many factors impact on an adolescent's decision whether to have sex, and if they're going to have sex, whether they're going to protect themselves. Things like, how they think about their future, if they have aspirations, their sense of belonging, connection to their community, how their parents' values, the behaviors of their parents and their peers. There's so many. Kirby's synthesis includes like 500 different risk and protective factors that really impact behavior of adolescents. Now, recognizing that young people need more than programs to support healthy decision-making, the Department of Health has had a long-standing commitment to an ecological, positive youth development approach. And we have a very strong research base for positive youth development. It's built on resiliency, prevention, asset development research, saying that positive youth development is an approach that communities can take to create services, opportunities, and supports that allow young people to develop to their full potential. It's an approach that recognizes the critical nature of cross-sector collaboration within communities.
And speaking of communities and cross-sector collaboration, what about community support and aspirational goals?
Well, some of the best evidence of this work, of the positive youth development approach, comes from certain programs, evidence-based programs in the field. Like, I'd like to mention the Carrera program that was developed in the Children's Aid Society. Now, this is not a boxed curriculum. It is an intensive, multi-year approach that supports healthy development by ensuring that teens have close, supportive relationships with adults. It builds on the teens' strengths and interests. It helps them succeed academically. It engages them in career development and professional thinking about their future vocation. It engages them in the arts and in sports. And it really prepares them for adulthood. And providing sex education is just one component of this program. Now, replicating Carrera is out of the reach for many of our communities because it is quite resource intensive and we don't have those kinds of funds, but it demonstrates the success of this community youth development approach and the role of risk and protective factors. Now, another program, another evidence-based program is TOP, the Teen Outreach Program, and that's currently being implemented in the city of Rochester. And this is another great model of a youth development program that emphasizes opportunities, assets, and community connections. Now, in TOP, in addition to getting sex education, young people do a service learning project. Now, service learning has been found to be a very effective strategy to prevent teen pregnancy. And the young people identify a problem in their community and then lead an effort to do something about it as a service learning project. So it's been a very successful, well-evaluated project.
This has been a lot of really terrific information and very helpful, in fact. And before we wrap up this program and start taking questions, let's hear again from some of the people in Rochester about the work that they're doing.
There are so many efforts that I'm very proud of locally. I think we have, as a community, really done some very wonderful and creative things in terms of addressing teen birth. One thing is developing youth leadership clubs with the support of the New York State Department of Health. We have 2 very active youth leadership clubs, Safe Sex Inc. and Youth for Change, that work together the past year. Month after month, contacting school board members, recruiting youth, recruiting parents to convince the school board to change its condom accessibility policy. And the vote was in favor of that change just a month ago. So the fact that youth leadership clubs can put their mind to something, work on something for an entire year, and see a result is just so promising.
Well, my group, we have parties. In our flyer, we include that there's going to be music and it's going to be food, and that's like the main thing people want to do. They're like, oh, it's going to be music, it's going to be food, I'm going to go there. And then when they're there, they'll get information.
I feel that teens or youth need to make sure that they're with the right groups. Sometimes when you're with the wrong group of people, it's sometimes easy to get sucked into that. It's best if you're friends with people that are more positive and do more positive things. An example is SOAR. I'm in SOAR, and with SOAR you learn how to be a leader.
I think youth need to get more involved in positive things that's going on in the community, so they get an experience of what to do in the future, so they head down the right path. Because colleges, they're gonna want you for the good things that you did in high school, so setting off now is important, and also being surrounded by positive people in a positive environment.
Some of the things that we're doing in the CAP program that I'm overseeing and that my team works with, some of the things we're doing that engages males, we're actually using different cultural arts components. A lot of the inner city males, they want to be a rapper. They want to do sports, they want to be a rapper. So what we started to do was really put an extensive music development program that doesn't just focus on music, but the business piece of it. It focuses on accounts, management, going to school, vocational training, as far as experiential learning how to actually not just go out and do carpentry work or contractual work, drywalling, but actually having your hands on and actually doing it. We deal with a lot of gang members, deal with a lot of young men that dropped out of school, hanging out on the corner, but you know, they are educated, they just want to be their own boss. And I think sometimes we get lost in the fact of some of this negative behavior of selling drugs and things of that nature, which it is bad. I'm not advocating that, but they're their own boss. You know, they could get up when they want, they can go, you know, get the money when they want, and we missing that point. So we put in some programs where they can be their own boss. You know, they could have their own business, they could have their own production company, their own visual arts company, their own photography, their own graphics. You know, we put in things that a lot of the young men, they like to go party. That's what they want to do. You want to party, be a promoter. You know, promote your own party. So when they realize these particular things, they kind of get engaged, you know, and they want to stay engaged.
What a powerful video, and it's clear that the people are doing this work. They're so passionate about what they're doing and committed to making a difference with the youth. It's fantastic. It's really terrific.
We are so proud at the Department of Health of the work that Lamar is doing in Rochester.
Let's jump right into some of the questions that have already come in. Here's the first question. What can we do to address teen pregnancy in rural areas where transportation and access to these services presents a barrier?
You know, that's a great question because, you know, New York is a very diverse state. We have one of the largest cities in the world, and we have very rural areas in the state as well. And I think that we look to really serve young people where they can be found and where they congregate. Schools, for example, is an excellent place to provide much of the programming in rural areas. We have programs that we fund in rural areas that provide these services after school. They work on providing them weekend, but then transportation always becomes a concern, and certainly access to reproductive health services is a concern with transportation. We do have programs that provide bus service or van service and have very set times in which they will transport young people so they can access services. But it is a unique problem in New York State.
That was a great question. That came in from Montgomery County in New York State. And here's a question that's actually come in from Washington, D.C. I'll frame it this way as written here. I work in a hospital where we're seeing many 13 and 15-year-old pregnancies. We typically have fathers room with the mother and the baby after giving birth. Many of the staff at this particular hospital are against the rooming in model where the fathers for the 13 and 14 year olds because they're teens themselves. Can you address this?
That's a very good question. I mean, I think we need to be very sensitive to the unique needs of teen parents. And I remember years ago being at a meeting out in California with a group of men that really did programming for teen fathers. And they brought some unique perspectives to me, one of which was, think of how hard it is for this young male. He's trying to adjust into a role which society is not supporting him in. He may himself never really have had a close relationship with his father and had a role model for himself. And now we're talking about him accepting the care of an infant. And we know with infants comes a tremendous economic cost, which he is also not in a position to provide as well. So he really has many things working against him. And I think that, you know, from my old days as a public health nurse where I did work with teen parents and worked in the home, it was always important to include them and try to support what is their assets. I mean, really drawing on something that Lamar just talked about, you know, maybe we may not like to see a teen father, but really look at what the strengths are that he's bringing to this. He may be the one who has that very low melodic voice that can sing the lullabies, and really start with really building up his self-esteem and really build his parenting skill. But it is a very challenging situation.
You talked about parenting skills, and here's a question. We didn't hear a lot today about the role of parents. What is the role of parents in pregnancy prevention?
Okay, Jean, do you want to talk a little about the focus groups?
Well, you know, parents are the primary source of information for youth about pregnancy, about sexual health. And in the focus groups, it was interesting. I mean, where's the best source of information? People often cited parents, but they had both positive and negative. Some people said, yes, I'd go to my mom for everything she tells me. Other people said, my mom lies to me and tells me if I'm going to have sex, I'm going to have cancer by taking the birth control pill. So it's a mixed bag with parents, although that they are they really are right there. We also did focus groups with parents. And parents want to provide information, but they're often, you know, have a hard time talking to their kids about sex and need help in communication strategies and learning how to do that.
Many of our programs actually do provide parent education specifically on talking to their children about sex, because it is a difficult topic for parents.
And Jane, I understand that the Act for Youth Center of Excellence has resources that might be of interest to our audience. Would you share those with us? Oh,
yeah. I would just like the folks out there to know that we have a fabulous, extensive website that is loaded with information about adolescent development, adolescent sexual health, positive youth development, and it includes publications and presentations that have been developed to support practitioners and policymakers. So all of this is freely available, and I encourage you to check us out.
Thank you, Jane, and thank you, Kristine, for being with us today. You're true advocates. You're on the front line. Your passion, your work that you're doing is highly commended, and we greatly appreciate you being here today.
Well, thank you for having us.
Thanks for having us.
My pleasure. And thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain Nurse Continuing Education Hours, CME, and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. An archive of this webcast will be on our website within 2 weeks. Please join us on April 19th for the next broadcast of Public Health Live on autism awareness, learn the signs, act early, the importance of developmental screening. I'm Joy L. Ray Alexander. Thanks for joining us on Public Health Live. Thank you so much. Thank you.